Well, welcome to this lecture. This is lecture number 8 in the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. As always, I want to take a moment to thank those who've made this lecture series possible, including the Pacific Island Health Officers Association, the University of Arizona Zuckerman College of Public Health, and the College of Micronesia Public Health Training Program. Now, without the backing of these institutions, then these lectures could not be provided. And of course, I want to thank you, the participant, for your dedication in improving yourself, no matter what your area of practice across the Pacific and beyond. I also want to thank the U.S. Centers for Disease Control and Prevention, from whom these lectures have been adapted, and I do want to point out that the opinions I express herein are my own and do not necessarily represent those of the CDC, PHOA, or COM-FSM. Now, thus far in this lecture series, we have talked about an introduction to what epidemiology is and its importance to NCDs. We've reviewed the burden of NCDs in the Pacific with an emphasis on related risk factors and the need for risk factor surveillance. We covered the burden of disease, including basic epidemiological measures such as incidence, prevalence, and disability-adjusted life years. We have talked about different types of descriptive and analytical studies. We discussed how to analyze and interpret surveillance using primarily descriptive epidemiology. We talked about how to prioritize public health problems in an environment of limited resources, and most recently we discussed the use of surveillance systems in NCD epidemiology. So in this video, we will be discussing data sources for NCD surveillance. Without appropriate data, as I've been stressing across this class, then we cannot make appropriate decisions regarding the services and interventions that we offer. And to have appropriate data, we need good sources from which to gather that data. And that is what this lecture is about today, where to find data for NCD surveillance. Today's lesson will cover a variety of topics related to data sources for NCD surveillance. These will include a brief review of surveillance data, the use of vital statistics as a data source, where to secure demographic data, the use of disease registries, health surveys, sentinel surveillance systems, the use of administrative data such as that gathered from hospitals, and finally, the use of census data. So at the end of this lesson, you will be able to discuss the strengths and weaknesses of each source of data, and then select and explain which data source you would use for a specific surveillance purpose. To begin with, we will take just a moment to refresh your memory on surveillance data, including indicators. From this list, can you recall what are the main categories of NCD surveillance data? Take a moment to see if you can identify them. The main categories are diseases and conditions, which you can see in the lower left corner, and risk factors, which is in the lower right corner. So ask yourself, what are some examples of diseases and conditions that we conduct surveillance for? There are quite a few listed on the slide already, including cancer, hypertension, and so forth. As you can see, these are all organized on the left side of the slide, whereas on the right side, we can see risk factors that we can conduct surveillance for to identify who is at risk for a specific health condition. This is also a good time to remind yourself of why we conduct risk factor surveillance when it comes to NCDs as opposed to disease surveillance. Recall that the primary reason for this is that when it comes to chronic conditions, or those that are of long duration and have a high medical, economic, and social cost, it is better to identify and control the risk factors than to wait for the onset of an illness that cannot be cured. Now we will discuss sources of data for NCD surveillance that focus primarily on risk factors, but which also include disease-based surveillance as well. The first of these will be vital statistics. What are vital statistics? Well, the term vital comes from the Latin term vitalis, which means of life. So vital statistics are those statistical measures which we gather that relate to life. These would include information on births, deaths, marriages, and divorces. A complete vital registration system is one in which all births and deaths in a population served are legally registered, and the causes of death are medically certified in an accurate manner. Vital registration is part of the civil registration system, which also includes information on marriages and divorces, which may be of interest in regards to mediating factors related to the health and well-being of a society. So how do we go about using vital statistics data? As you can see, there are a variety of ways in which this data can be used, including identifying differences in the health status of a population by various demographic characteristics. These might include differences in age, gender, ethnicity, and so forth as related to a specific disease. Once we have identified that specific demographic element of the population, which is at higher risk, then we can target our interventions on those specific elements of the population. We can also use demographics to identify geographic areas of risk, such as where there are higher rates of cancer, and once again, use this to target interventions on those areas of need. We can also use vital statistics to monitor deaths in the population and to determine which were preventable. It is important that death certificates be appropriately completed in order for this to be effective. We also use vital statistics data to generate hypotheses or educated guesses about why specific elements of the population are at increased risk. We can then test these hypotheses to determine what types of interventions might be most effective in the at-risk populations. As I mentioned on the previous slide, one way of collecting vital statistics data is through death certificates. Death certificates are forms completed for every individual in a population at the time of death. Many data items can be included on the standard death certificate for a country, and the exact data that are included will vary from country to country and region to region. The general categories of data that are collected are listed on the slide. Good data to have access to would be name, social security or other identifying number, father and mother's names, including mother's maiden name, and of course, good data related to contributing factors to the death, such as tobacco use, high-risk pregnancy, injury, and so forth. And finally, demographic data such as age at death, gender, residence, education level, ethnicity, and occupation. Data on the actual cause of death and contributing factors should also be included. This data is highly useful in tracking disease trends in the population, but it is contingent upon complete and accurate forms. So, what is mortality data used for? The use of mortality data as an estimate of the occurrence of a disease or condition in the population is most appropriate for conditions that are usually fatal, such as stage 4 cancers, those that can be ascertained easily at the time of death, and those for which risk factors are well established, such as lung cancer, heart disease, or even diabetes. The data shown in this slide comes from a series of publications in the journal Lancet and shows the state of the world's civil registration systems. Approximately 25% of the world's population lives in areas with complete civil registration systems. Complete is defined as more than 90% of deaths appropriately registered at the time of death. Appropriate is more than just a completed death certificate, but is a death certificate that is completely filled out and includes correct information on the cause of death and underlying risk factors. For the physicians in the audience, this includes the specific chain of events leading to the death, not just cardiopulmonary arrest, which is what everyone dies from. As you can see, in the Western Pacific, only about 12% of the population live in areas with complete civil registration systems. In developing countries, there tends to be underreporting of deaths. While some areas may have high reporting, such as the urban areas of our islands, overall there tends to be underreporting as a whole. Among registered deaths in the developing world, accurate cause of death data is only available in 1 of every 3 deaths. Even those for which a cause of death is available often provide no details, but rather place deaths into generic categories such as accident, violence, or disease. Such provides little information from which conclusions can be drawn. Thus, civil registries are not always a reliable source of epidemiological data. This is an important area in which countries should invest both time as well as resources. What is a verbal autopsy? Because many countries have weak vital registration systems, if they have one at all, verbal autopsy is an accepted source of information about the causes of death in a population. Although there are significant limitations on the validity of data, verbal autopsy may be the only way of estimating causes of death in the population. As you can see, a verbal autopsy involves interviewing family members and others regarding the period leading up to the death, including identifying risk factors, and then ascertaining the most likely cause of death. These can then be assigned ICD-10 codes, a classification system of disease which we spoke of in an earlier lecture. Next, we will discuss demographic surveillance sites as a source of health information. So, what are demographic surveillance sites? Demographic surveillance is the process of identifying risk factors and the corresponding changes in rates of births, deaths, and migration in a population over time. Surveillance systems are often created around specific intervention studies and then later converted into standing DSS sites that can form a platform for further studies. Worldwide, there are approximately 30 DSS sites, primarily in Africa, Asia, and in the Americas. At most sites, core demographic data such as age, gender, and ethnicity are supplemented with social and economic factors related to the population and changes in health, such as education, employment, migration, and so forth. There are many advantages of using DSS. These include the gathering of more complete data on vital events in the population as related to specific risk factors. For example, you might gather data specifically on all causes of death related to a specific cancer. Here in the Pacific, we might want to look at oral cancers. Or you could look at birth defects related to the availability of prenatal care. The idea is that you gather additional data on a specific health condition in the population. As you can see, starting to gather specific data can lead to the creation of a robust vital statistics registry later on. There are also disadvantages to the DSS system. These include the fact that because you are gathering very specific data on a specific subset of the population, the data gathered and the conclusions drawn may not be generalizable to the larger population. These systems can also be expensive to maintain in terms of human and other resources. Next, we will cover disease registries. So, what are disease registries? Registries systematically collect data about patients or individuals with a specific disease, condition, or exposure to a risk factor. Data can be collected from healthcare providers, but in some cases it may come from specific sources, such as public health laboratories where those exist, hospital laboratories, or even pathology departments if those are present. Disease registries are most commonly seen for cancers, which are relatively rare in the population but are also likely to be noticed by healthcare providers. In the Pacific, we have the Pacific Regional Central Cancer Registry, which operates under the auspices of the United States Centers for Disease Control and Prevention, as well as the John A. Burns School of Medicine at the University of Hawaii. There are both advantages as well as disadvantages to disease registries. While registries can capture morbidity data, they can also be linked to other sources of data, such as pathology reports, to provide a greater picture of disease trends. However, they may lack all of the necessary demographic and medical data, depending upon the source of the registry, that is needed to create this complete picture of disease trends. This is particularly true as it relates to social epidemiological issues such as education and employment. Registries are a useful, focused tool, but there are challenges to their implementation. For epidemiological purposes, registries may be useful for estimating burdens of disease. However, having a registry that is actually representative of all cases and also having an accurate denominator or census data from which to calculate the burden of disease can be difficult. However, it should be remembered that some data, even if not complete, is better than no data at all, and as such, efforts should be made to establish disease registries. The next source of health data that we will discuss will be surveys. What are health surveys? Unlike vital registries or disease registries, which are largely passive surveillance systems, health surveys are active surveillance systems. In a health survey, which I'm sure you are aware, a health official actually contacts members of the population to administer a standardized survey or questionnaire. This may take place at regular intervals, such as annually. The data collected from the survey may represent a cross-section of the population if it was done appropriately. Just as with other sources of data, there are both advantages and disadvantages to health surveys. Health surveys are a way to collect information on risk factors or conditions that do not routinely come to the attention of healthcare providers. However, gathering this information, because it is active surveillance, is more costly than passive or secondary data collection. The WHO STEPS survey, which we talked about in a past lecture, is a procedure for using surveys as well as gathering physical and clinical measurements in order to conduct NCD risk factor surveillance. As many of you know, it is a graduated approach to data collection that involves several steps as shown on the slide. The Global Adult Tobacco Survey, GATS, is another example of a health survey. It includes a standardized set of questions. Those who wish to use the GATS can select specific indicators and the associated question banks for use in their own country or region. GATS illustrates an important point, or the global use of a standard set of questions in order to gather standardized data across multiple locations. The point here is, if there exists a survey that has been tested in other settings and is globally or regionally accepted, then jurisdictions should use these surveys as opposed to creating their own. Our next topic will be Sentinel surveillance systems. Sentinel systems are not widely used for NCD surveillance. They are primarily used for infectious diseases. However, they can still play a role in appropriate circumstances. Well, what are Sentinel surveillance systems? Well, it is the collection, analysis, interpretation, and dissemination of information from a select subset of the population. It can be a short-term system or can lead to long-term surveillance. Data is generally acquired from healthcare providers. This can include hospitals, clinics, laboratories, or even situationally specific places such as refugee camps, arts festivals, large-scale meetings, conventions, and so forth. Sentinel systems are often used for infectious diseases. For example, a standard for influenza surveillance is to conduct sentinel surveillance for pneumonia and influenza-like illness at a respective subset of hospitals, clinics, and laboratories. Here we see some examples of sentinel surveillance systems for non-communicable diseases. Resources may not always allow a sentinel surveillance system to be established because of a lack of manpower, finances, and so forth.
It's 16 hours.
Administrative data is collected in every country. If it can be accessed, it can be an inexpensive method of secondary data collection that can be used to answer questions about health conditions in a country or a region. So, what is administrative data? Administrative data is not collected for epidemiological surveillance reasons, but for administrative and business reasons. Primarily, this is data collected by hospitals for billing and other healthcare administration purposes. However, as you can see from the examples on the slide, it can contain valuable information that can be used for epidemiological purposes as well. Just as with other sources of NCD surveillance data, there are advantages and disadvantages to using administrative data. Advantages include high coverage in the population for those who are accessing healthcare services, such as those who routinely go to the hospital or to the clinics, and the fact that it has already been collected and must only be accessed and then analyzed for meaning specific to the surveillance purposes. However, there are several disadvantages as well. These include incorrect diagnoses that may be present in the system, especially for conditions that are typically underrepresented in the population. Additionally, the records generally contain no clinical data since they are being used for administrative purposes. However, clinical data can be obtained from clinical or laboratory records and cross-referenced with the administrative data. Thus far, we have talked about vital registries, demographic surveillance, disease registries, health surveys, sentinel systems, and administrative data. The last source of data we will be talking about is census data. What then is census data? A census is a count of an entire population and is often implemented by governments on a regular basis, such as every 10 years. They can be used for planning purposes and following population growth or decline trends. They can be used to identify urban versus rural areas, as well as differences in population cohorts showing what percentage of the population is from different age groups. Information gathered includes the numbers of individuals in a household, their employment data, income data, marital status, family size, ages, and ethnicity. It can be used to plan for health services. So, for example, if you see that the percentage of the population aged 65 or above is rising, then you will need to plan to provide services to an older population. In some countries, health-related questions can be added to census. For example, in countries which do not do household surveys on a routine basis, a census would be a chance to include health-related data in routine gathering procedures. Of course, some communities are difficult to reach because of distance, transportation, and so forth, and there is also the issue of the technological capacity to both collect and analyze the information. Well, once again, you have done it. You've made it through. Congratulations, and I do hope that you've learned something from today's discussion. As always, I want to thank our sponsors for supporting these lectures. But most of all, I want to thank you for your hard work and dedication. I know that you're busy people, but you have chosen to take time away to improve yourself in regards to epidemiology. So well done. I also want to ask that if you've been given time away from your job to complete these video lectures, that you thank your supervisor for their support as well. Now, as always, please send me an email with your 3 learning points. And do notice that my email address has changed. I am no longer using the FNU address, but am now using a Gmail address. So please update accordingly. Once you've sent me your 3 learning points, you're ready for lecture number 9, NCD Prevention and Control, which will be released next month.